made a self-referral to your clinic, primary complaint of right anterior hip pain. He has seen an orthopedist in the past month who feels that the total hip arthroplasty is in the patient's future, but they want to try conservative treatment before they even think about it. It hurts to get out of bed. Intermittent hip pain aggravated by squatting, going upstairs, hip rotation. The pain has kept him from his regular gym activities, which is treadmill and weightlifting. His goal is to return to a previous level of function in his ADLs. Okay, are we ready?
Yes, sir.
Kevin, you're not part of this group.
No, he's ours.
He wishes.
All right. So, what do you guys think it is? Or it says it already.
It's OA.
OA. Hip osteoarthritis. Okay. What's the demographic typically for this diagnosis?
People over 50 years old.
People over 50. And how old am I?
60.
Whoa!
61.
Whoa! You just failed the course.
That's failure. Critical.
46.
That's a critical safety. 46. So I'm a couple years away. All right. All right. We're gonna take turns answering. All right. I don't want one person answering everything. That makes me nervous. All right. So you guys figure out the order. Causes of this diagnosis. What is osteoarthritis? I don't know what that is. Never heard of it.
Defective integrity of articular cartilage, bone on bone.
So bone on bone. No more cartilage, bone on bone, and then these osteophytes grow, which causes pain and all that.
This is
All
a
right.
bad setup. I need you guys to spread out.
Spread out?
There you
Got my good side?
The director.
All right. Two possible sets of criteria set by the American College of Rheumatology to diagnose hip osteoarthritis. Again, the same person cannot answer twice.
Internal.
They didn't mean.
They're both answering together. Are you not sitting up here, Mr. Mitchell? Please.
What does it look like in blue?
All right.
Things to do.
All right. You guys missed the golden age. You used to sit up here and throw things at her. All right. All right. Go. What are the two ways according to the American College of Osteoarthritis?
Internal rotation, less than 15 degrees, and
Yes.
Flexion, less than 115 degrees.
And
That's one
you're missing the biggest part of that one. Age.
So older than 50 degrees.
Older than 50 degrees. Okay, that's one. What's the next one?
And then that's the first set. The second
Four.
set would be internal rotation more than 15 degrees with morning stiffness, less than 60 minutes once you wake up.
Right, so they feel very stiff, but after less than 60 minutes they move around and the pain decreases. So it's either or according to the American College of Rheumatology. Okay, what activities, movements would increase this patient's pain?
Deep squat, prolonged sitting, and twisting on the involved lower extremity.
So what's that? What does that mean, twisting on the in?
It's like you're turning to get something. So like, let's say this one's
Let's
up.
twist. Do it!
This is weren't even born when that song came out.
Just like this.
Yeah,
Yes.
Alan.
There you go. I played Yakety Yak for my kids. You know that song?
Yeah.
The classic.
Yakety yak.
No, Yakety Yak. Don't vote. No? All right. It's a great song. All right. So twisting on the involved side. Correct. What else?
Prolonged sitting.
Prolonged sitting
Hip flexion.
with hip flexion of 90 degrees. All right. What's the last one?
Deep squat.
A deep squat, which is an activity of daily living. People have to squat all the time. Right? All right. What time of the day?
Morning.
Ryan.
You just want the easy one?
I already said coming to you.
Yeah.
Over
Get
there.
into the screen.
You're hanging out way by yourself. Go over there.
He doesn't want. He doesn't want. Okay.
That thing too.
All right.
All right, Ryan. Manual muscle test would reveal weakness in which hip movements?
Ipsilateral hip abductors.
What are the hip abductors?
Glute medius, glute minimus, and tensor fascia lata.
Very good. TFL. What else is weak? Next,
Deep six.
the deep six. They also the external rotators / internal. We'll call it external rotators. What else?
Flexors.
No.
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 Flexors.
Yeah.
No, we don't.
Oh, extensors. Sorry.
Extensors. What muscles do extension?
Hamstring and glute max.
Okay, very good. All right. Decreased range of motion in which structures? The osteokinematics. You will see decreased motion in what?
Hip extension, hip external rotation, and hip abduction.
Yes, that is correct. Arthrokinematics. When you test the joint integrity, what do you find?
We find the tight anterior part.
Tight anterior part.
Capsule.
Oh, capsule.
And how do you test the integrity of the anterior
I
capsule?
will do the anterior glide.
So you're gonna show us one soon. So the anterior glide, yes, you do glides to assess integrity, also to treat. Does that make sense? Okay. One person didn't know that in the practical, and that person will remain nameless.
In this class?
Yes.
No.
Don't get me started. All right. So show us the special test. Everyone has become an expert in one special test, which will make them great clinicians. The first special test for this diagnosis is the Faber. Who is performing the Faber on who? I can move if you need me to.
Oh, test number 2.
Okay, I'll do number one.
Favor?
Yeah.
Faber.
Okay.
Do it here so that the camera can see it.
Okay, patient, lie down. Fine. Okay, good. Now, assuming that the affected leg is the right, so he's gonna do the number 4 position on the leg, and the clinician will hold on the SIS on the side, okay, and then press down. And then press down as far as you can.
Simulating.
Okay, and a positive sign would be what?
Yeah, a positive sign is pain
Where?
in the front of the thigh.
Or?
Or if there's pain at the back, it's on the sacroiliac joint. Okay.
No. So pain in the lower back is sacroiliac.
Oh, yeah.
But what's a positive sign for hip osteoarthritis?
The front. Here.
Anterior or posterior?
Okay, anterior.
So they can have pain in the anterior or posterior capsule or thigh. That's a positive sign for hip osteoarthritis. If they have pain in the lower back, specifically the SI joint, that's a positive sign for SI joint. You get the difference? Very good. What's the next test?
Next test is so
Which one are you doing?
number 2.
What is number? I don't know what number. That sounds like a restaurant. Number 2?
Scar test.
Yeah.
Scour.
Scour.
Scour
I
test.
think
So
it starts in
it's,
this position.
Yeah. So 1990, and you put pressure on the kneecap, pushing down, and you do internal right, internal rotation and external rotation. And the positive side is patient feel pain.
All right, good but not great, because you're not really putting too much pressure on that joint. So, Sue-Ann, how would you do it?
Give pain.
Still no good. How would you do it? You don't have a stool. We gave it away. What would you do? Get up on the table. Really push down. You don't want to push it on the kneecap. There'll be pain there. Push, yeah, put your weight into it, and now do internal and external. That really puts pressure on the hip joint. I'm fine with internal and external or AB and adduction. Show us that. Pushing down. You have no. Get up there. Get up there. Push down, and then do it. That's fine too. You have a positive sign with either. I like internal, external because it causes more pain, as we discussed. Good. That's the scour. What's the next one?
You want me to walk for 6 minutes?
Oh, the 6-minute walk test. So describe the 6-minute walk test. I know you want to leave, so yes, let's do the 6-minute walk test.
That's why he went
So
first.
it's itching to go already.
Go.
Let's walk to the train.
Yeah, if they can't complete the 6-minute walk test because they have pain, or if their distance is really short, it may indicate that they have osteoarthritis.
Right, so typically you have 2 cones. You have a cone here and a cone here, which can be 100 feet apart, and you have the patient literally just walk in circles around the cone. So now you can tell, if you know this is 100 feet, it's easier for you to track exactly how many feet they walk. You count how many times they do it. Got it? That's an easy way that's otherwise how are you gonna really rate them? If we're in Colorado, they could walk for 6 minutes, but we don't have it in New York. So that's how I like to do it. And yes, if they can't complete the test, you record how many feet they walked and what time. If they do complete the test, you still record how many feet they walked and you write the full time. Good, that's good for testing. It's also good to progression, right? If they're only able to walk 1,000 feet, and now after treatment they can walk 2,000 feet, that's great. And the last test is what? Huh?
Well, there's 2. Squat. So
Oh,
you can,
squat. How do you do the squat test?
well, they obviously they're going to squat, but you want to mark the degree of flexion where they get pain. So you can also, like Dr. Nansen, you can progress it. If their flexion is kind of minimal, as they improve, hopefully they'll get greater degree of flexion.
What's a positive sign for the squat test?
Pain.
Pain. Yes. So
And
you
there's
have
also
this-
Trendelenburg.
should we go over the Trendelenburg sign again? Patient
we got it.
stands, you look at both PSISs, and you look for a, right, you got that one? All right, very good. Red flag,
Sign-
Allen's, what's the sign of the buttocks?
So pretty much it's pain in the glutes with hip and knee flexion and supine, and it's less pain when they're performing a single leg raise.
At how many degrees?
to 90.
30. So you do a passive straight leg raise, and they have pain in the lower back or in the glutes at 30 degrees or less. That's clearly not a sign of tight muscles, right? Everyone in this room, no matter how tight you are, even Josh who's injured, I could lift your legs 30 degrees. You should be pain-free.
I don't know.
All right. If you're lying flat on your back, I bet you I could get 30 degrees pain-free. I'll cover your mouth and I'll lift your leg 30 degrees. If the patient, you cannot lift the patient above 30 degrees, either their pain stops them or you feel something stop them. That means what?
Then it's
It means it's a non-musculoskeletal issue.
It's a non-musculoskeletal
Possibly
issue.
cancer.
Possibly a neoplasm or a tumor, and they need to be referred
Or
to a
CNS
specialist,
compromise.
right? That's not normal, that if you can't lift their leg above 30 degrees. No, it could be a tumor in the lower back, somewhere that's stopping this movement. So you don't scare them and say, you say, I don't think your issue is musculoskeletal. You should go back to your doctor. And you call the doctor and say, this person might have the sign of the buttocks. What do I know? I'm only PT or PTA. What do we know? Which we know a lot, but you know, because the doctor might have missed it. Right, correct. And you don't want to accuse the doctor of missing it. So you say, I think something's going on, and then they thank you or don't thank you later. Okay, very good. So plan of care, 2 phases. You said what was tight?
Anterior hip muscle.
What's going on? You have a sandwich in there? No. All right. So we're stretching the anterior hip. How do we stretch the anterior hip?
Lunge. Okay, I'll do it.
You're progressively going farther away.
He doesn't like being on camera.
He's
How did you
modest.
figure that out?
Modest.
Okay. All right. So you do the front lunge, the stretchy anterior hip, straight body.
Nice.
Yeah. So good. How would you stretch the patient?
Stretch the
So that's a
patient.
good way to teach the patient. I love it. How would you stretch the patient?
So it can be either.
Show us.
Patient.
Okay, you're here. Thanks.
You're stretching. You're going to stretch the patient's left anterior hip, or hip flexors. How would you stretch the patient's left hip flexors,
Left hip flex.
or right hip flexors? I could care less. Just so we.
Stretch
So
one
we need
of
to
them.
align to
Patient lies supine.
Okay, so if I remember correctly, I hope. Okay, so show me that this is the affected side. So I'm just gonna have to do this. I'm gonna stop her.
That's the affected
Oh.
side.
Yeah.
So you're not stretching their anterior hip.
With your hip. Oops.
How would you stretch their anterior hip?
Okay, wait a minute. Yeah. Oh, yeah.
You could do it as a bind.
You could do it in supine.
So stretch.
Oh, you hold it down.
You're just gonna do as either knee or shin.
You're going to stretch the patient.
Okay. Right. So supine. Okay. And their hip. Can you move further? Okay. Thanks. Okay. Okay. Scoot towards a little bit here. Okay. Thanks. I think it's okay. So and their hip. Okay. So here, with me back. It's okay, right?
You're stretching and you're stretching their
Oh.
anterior thigh.
And their thigh. Okay. So.
You're getting the posterior right now.
Posterior. I kind of lost. Okay.
Okay,
Take
somebody.
over.
That's why we work in groups.
Tag.
Go.
Okay.
Oh, it's like a WWE
I'm
wrestling.
going to take her back for a moment.
That's right.
So, for a ride.
Wow.
So, no, you can stay here, come up closer.
You might want to take the shoes off.
Actually,
No,
you're gonna be
the shoes are off.
No.
just like this, over here. That one. And then, let's say this side's affected, you can lie down. I guess I'll put this up, come a little bit closer towards me, and then I'm gonna push down like that. Or you could be prone.
No, wait.
That's good.
That's good, except if you do a little knee flexion.
Reflection.
What do you mean? Oh,
No, with your foot. It's a fancy move.
Push it in.
there we go. 1 second, don't break it. There we go. Like that.
Yeah, wait. Come a little bit more. A little bit more. Yeah.
Her
No,
foot, her
off the
foot can go
table.
into your shoulder. You can use your body. weight.
Oh, I see.
I can tell you that she doesn't need stretching in that joint there.
Yeah.
No.
It's like, so
Like-
that's kind
With
of
the
awkward because I
leg,
feel like I
yeah.
might.
Right.
There you
Alan's.
go.
Look. No hands. You see, so that really gets the anterior thigh. Thank you. Got it? You could do it in prone, but this is probably the easiest on your body. Good. All right. But the patient has stretched it. All right. What else?
Adduction.
Adduction. How do you stretch
Butterfly?
it? Show us how you would stretch the patient and how the patient would stretch themselves.
So,
So-
oh,
Yeah,
no. A
stretch
self
it.
stretch is like this.
Self-stretch, good. And yeah, and how would you stretch the patient?
Oh, I could just do it for her.
So come around so that, oh, that's,
Oh.
so that-
You can bend your legs.
You know, you notice, Mr. Mitchell?
Just one time.
The patient's in pain, and these therapists are saying, move left, go this, further down the
Okay.
table.
I move like this, keep that stable, go out like that. Or, actually, yeah, there we go.
Yeah, but you can also do it like this.
Oh, just as good. And then stabilize over here.
Just that is good.
Like that.
How about, wait, show Mr. Mitchell your body.
Oh,
Oh, that.
There.
There we
Much
go, look at
better.
that.
better?
Much better.
And now kind of do this like,
All right, good, you got it? Good, very good. And hip external rotators, how do you stretch
That's
that?
gonna be the list.
Do the list.
How would you stretch the patient's hip external rotators? Yeah. That, oh, good, no,
Whatever,
that's
that's-
good,
you're
that's
good.
good. That way's good,
And
that way's good. How about in, somebody else, how about in supine?
Somebody stretch.
Well, first stretch yourself, That way's good. And now
And then you
stretch
could
the
push-
patient.
I mean,
Or, actually, there
Don't
we
make
go.
it so, no, wait, relax, just look, life is easy, straighten.
Oh, guys.
Easy, you're doing like,
I guess.
I don't know, like you're like,
I feel like I'm getting more force pushing that way.
this way, look, it's so easy, just get your,
Or you can get on the table and do body weight.
you can do body weight,
Yeah,
yeah.
sure.
But you know what, this comes with when you practice. After the third lawsuit. I'm kidding, all right, so, strengthening weak musculature, so we're gonna start not weight bearing on the table. Non-weight bearing, show us. This should all be obvious, abduction. Bottom leg is bent. Bottom leg is bent, you wanna make sure there's no hip flexion. The hip is like that. I always tell the patient, have your leg behind the knee, or you could do it against the wall where their foot is touching the wall. So you know they're doing it properly. That's abduction, good. What's next? Extension, strengthening. Non-weight bearing, I'll buy that. You like that?
Mm-hmm.
External rotation. Yes, clamshells, but this stays. Good. TheraBand as needed. Weight cuff as needed. What do you have, tickets to the show tonight? You're dying to get at? All right, anyway.
I'm with the,
All right.
it's like
So-
I'm hungry at this time.
I hear you,
It's like-
All right. What else? So, good. Joint moves. Show us, who's gonna show us, joint moves?
As Joe would say. Joint
Who is gonna show us a PA glide, an AP glide, and a distraction? Do you know how to do all those? Refer back to the joint moves lecture. Get good at all three. Again, some people feel they didn't have to practice and then they had to do a joint move. Things didn't work out as they should have. So please make sure you're doing it. I'm not looking at anybody in particular, especially you know what you got on your practicals. Be good at all these things. Any questions on any of those moves, which we went over? You're good with those? All right. Good. And you're gonna do what grades in the early stages? 1s and 2s. All right. Initiate walking protocol. So before they go to they start walking on the treadmill, let's say, what would you have them do, guys?
Stationary bike.
Stationary bike sounds good. Elliptical machine, maybe? It's another good choice. It's more realistic for walking. We didn't discuss it in our little groups. I'm not throwing you under the bus, but I think elliptical machine's a good idea. Good. What about the cane? How do they use the cane?
on the uninvolved side.
On the uninvolved side. What if they use the cane for the stairs? Does the cane go up first or the cane go up second?
Second.
Okay. All right, let's see. Your patient must walk up 3 flights of stairs to get into his apartment and is always in 4 out of 10 pain. What advice could you give them?
Take the elevator.
Take the elevator.
Or
These
one
these
step
people
at
are
a time.
Upper East Side people, they think they have elevators.
Yeah.
Or one step at a time, yes.
And good foot up first.
Good foot up first. So you don't have to go step over step if that's too painful. One step at a time, the good foot going first, right? Good foot goes to,
Heaven.
bad foot goes to.
Hell.
That's right. Okay, now phase 2. More aggressive stretch for which ones?
It's still the same. You just
A more aggressive stretch for what?
Classy ass.
Yes, so,
I mean, it's hard to push.
so no, I would say the standing one is definitely, I can't even do it, but the standing one is more aggressive than the lying down one, agreed? That's more aggressive,
Yeah.
right? Pigeon pose,
That's only because you have jeans on.
Tight
sure,
jeans.
sure.
I knew you had.
Good, the standing lunge is probably more aggressive than the patient doing the Thomas test on their own, right? And what's the last one? Oh, adductors, you could have the patient push more. Or try to do a split and then lean in the floor like this, right? Good, that's more aggressive. How about more aggressive, what else?
Well, now we just did the strengthening, so everything. can be
Now
done
in standing, so how would you do abduction in standing?
With our back.
Theraband or weight, good. And then what's the other one? External rotation in standing. Extension in standing, good. External rotation in standing. Yeah, it's going a little squat and out with a Theraband. Up, squat, out. Just like that. All right. Joint mobs, again, now you're doing what grades? Threes and fours. Your patient's ready for the treadmill. What are the best parameters to do? Start working on the treadmill?
Slow, short duration, low incline.
No incline.
No.
Not running, comfortable walking, okay. Joint protection strategies. Your patient carries groceries 2 blocks from, you could say the joke if you want, from the store to the home. What's the best way to perform this activity?
Fresh direct.
Fresh direct.
I passed it on.
You're on camera, Kevin. Okay. All right, so
Anyway,
if you can't do fresh direct, they should hold their groceries
They,
on.
sorry.
No, they should hold the cow.
They hold on the involved side. Remember we talked about the Trendelenburg
Oh,
side?
yeah.
So if this is the strong side, you want to hold on this side so it holds the leg up.
Okay, very good. Your patient lifts boxes from the floor to a high shelf 3-4 times a day and is always in 4 out of 10 pain. Suin, what advice could you give this patient?
So instead lifting things like this, you can put your fat side there, and then you do half kneeling.
Half kneeling might be less painful. Good. What else? What else could you do?
You can put it here and then rest, and then put it here and rest.
And then, right, instead of going straight to the high shelf, go slow area. Good. Or put the box, try to get the box, really low so you're not going to the deep squats for a long period. Very good. Any questions for this group?
I think we kind of nailed it.
I'm impressed, very impressed. All right, group number 2. 32-year-old recreational runner comes to your clinic complaining of right lateral knee pain. He's first experienced it 6 weeks ago. 2 weeks prior to the symptoms onset, he initiated a marathon training. He made big jumps in the mileage, and now he's in a lot of pain. Symptoms have gradually worsened from 3 out of 10 pain only when running to now running pain even at rest. He's no longer able to run downhill due to immediate pain. Patient's past medical history is otherwise not remarkable. His goal is to return to running. Okay, based on this patient's story, you suspect he might have IT band syndrome. Okay, very good. What aspect of this patient life? Again, I want everyone answering questions. What aspects of his lifestyle would cause this injury?
Downhill running. What the ruin this way?
Yeah.
Downhill running.
Downhill running for sure.
Increasing his distance too fast.
Increasing his distance too fast. What else?
Sitting.
Sitting, or in general overuse, right? Very good. Explain to your patient what anatomically is going on. Do we have a knee here?
We have a bunch of them.
Take Frankie to Butch's knee.
Go free.
Oh, there's a knee right there. No, right there, but onto your left. To your left, Mike.
Other
Now to your right.
Aha.
You can use Frank. All right.
Mr. Frank.
Here, what do we got? What's going on anatomically? Because the patient has no clue what's going on.
Okay, so the distal IT band is getting compressed with the lateral femoral epicondyle every time he's
Every time what? So what's going on? So every time he does what?
flexion.
Flexion to how many degrees?
30 degrees.
At flexion to 30 degrees, what is going on?
It's getting compressed
Where?
here on the lateral, in the femoral epicondyle.
No, it's like here.
Gertie's tubercle.
Gertie's tubercle. Where is Gertie's tubercle?
Right chair.
Yes, very good. Gertie's tubercle is right around here. So every time he flexes, Gertie's, the distal IT band gets screwed up, jumps over, or that piece of bone over the lateral condyle every time around 30 degrees. That 30 degrees is known as what?
The impingement zone.
Don't listen. It's time. This is your chance to speak in front of this group. They're not going to throw anything at you, right? Yes. Good. So a patient's going to say, "I have IT. What is IT band syndrome?" And you're going to say, "Speak like not. You're smarter than every patient you work with. They don't know this stuff."
The IT band is compressed on the greater tubercle every time the flexing release.
That's also like, but yes, correct. Yes. Very good. So what is that? What is that called? That 30 degrees? The impingement zone. Right. And if you open a bar called the impingement zone, I know where it came from. Very good. Good. So very good, Diana. Thank you. What are some extrinsic factors that lead to this diagnosis?
Poor footwear.
Okay. Poor footwear.
Too many miles.
Too many miles. Yes. Premature increase in mileage. What else?
No resting time.
Okay.
Poor recovery.
Downhill running.
Downhill running. What else?
Reflection to 90 degrees.
Yes, sits all day. So he trains for a marathon, like this guy, and then sits all day at class. It's a bad combination, right? Because sitting at 90 degrees of flexion puts a ton of pressure on the distal IT band, and running, especially downhill, puts a ton of pressure on the distal IT band. I'm gonna party with that guy. Let's see. Okay, walking downstairs. How do we know it's getting worse? So at first it was hurting when? Only
During activity.
and now it hurts even during rest, so you know it has progressed. Okay. So that was some extrinsic factors. Good. So upon palpation, where would the patient feel pain?
Gertie's tubercle.
Gertie's tubercle, which is down here. And then where else might they feel pain? At the lateral femoral epicondyle. Very good. Manual muscle test will reveal what?
Weakness in the glute minimus, medius, and the TFL,
Yes.
as well as the core.
The obturators?
Abductors.
Abductors. Yeah, those are the obturators.
And weak core.
And weak core, yes. Weak core, weak all the muscles that do abduction. Very good. What else?
And your hip flexors.
Why? Hip flexors, why? Ah, yes, because TFL is also a hip flexor. So if your TFL is weak, it could affect hip flexion. Very good, Kevin. Very good. And weak core, like you said. Good. So you already formulated this thing in your brain, right?
Mm-hmm.
Good. Based on the manual muscle test, you have the patient do a single leg stance on the affected lower extremity. Can somebody please show us what you might see with this patient?
Miserable malalignment.
The miserable malalignment, which looks like what? You have to go in your underwear and take off your shirt so we can really see it.
Not on camera.
No, he'll do it too. All right. What is miserable malalignment?
Like
Yes, so the patient has valgus force on the knee. You see that? Valgus force. He has a internal rotation of the hip, and he has a deduction of the hip. Show us again. Very good. So increased hip adduction, increased knee internal rotation, increased valgus force. So that just proves your point even more so. You want to test the patient's core, right? How would we do the patient's core? How would we test it?
single leg bridge.
Anybody not know the single leg bridge? Somebody show us a single leg bridge.
D-nice.
D-nice. So the patient lies supine, takes one leg, lifts it off, and lifts up, holds that. Full strength is what?
23 seconds.
23 seconds. If you notice, it's not gender specific for some reason, even though so many tests are. 23 seconds. Good. I'm gonna see. You definitely got 23 seconds.
Bring your arms up.
All right, 23. If he up high, if he goes 10 degrees, show us like a weakness. If he drops 10 degrees, test is over. Go up again. If he sways back and forth 10 degrees, test is over. If he stays solid like a rock, 23 degrees, he has full core strength. Very good.
23 seconds.
23 seconds, full core
Not 23
strength. Very good.
degrees.
All right. Good. You'll have tightness in which structures?
Hamstrings, gastros, and
So hamstring tightness, gastroc and soleus tightness, right? And finally where?
TF.
Yeah, the lateral structures. Obviously your IT band will be tight. Very good. All right, what special tests? Show us the special tests.
Thomas test. You're the
I'll do it on
tester.
someone else.
Kevin, look up.
Wait, we'll have positive tests with you, positive signs with you, right?
Yeah, you go.
No, don't do it. All right, the Thomas test, which you kind of saw with the first group, right?
Can you lift him?
So, have to go, yeah, and then.
I didn't find out why, Suin, because you did not email me. No, you start off sitting, and then the patient takes one leg, brings it into his chest,
Take this
and then
one,
lies down.
and lie down.
There you go.
And then I'm seeing,
Look at that go lateral.
All right, so show us all the positive signs.
if it were positive, his leg would be raised up.
So that means, if it's raised up like this,
His hip flexor's tight.
hip flexor's tight, you got that?
And if it's-
If he's able to bring it all the way down, but he can't bend his knee to 90 degrees, just naturally, you don't ask him to do anything, that's tightness in what?
Quads.
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 Yes, correct. But for this diagnosis, you're looking for what?
Hip flexor.
moving
No.
lateral.
Right,
CT
lateral
sway
sailing
down.
of the whole leg. If the leg, look, if the leg starts going this way naturally, he clearly has lateral tight structures. Got that? Good, that's Thomas. What's the next test?
Noble compression.
The noble compression test. How do we do the noble compression test?
You gonna show it on me?
Can we do it on Ryan, because he's wearing shorts? Do you mind, Ryan?
Right on.
You get an extra 10 points
You're wearing shorts.
somewhere.
All right.
Kidding. You're wearing shorts. Good, so do it on Ryan.
You do it, you're right in front of him.
Face the camera.
Come here, soy. No, stay
Face
up.
the camera.
Oh, wait.
Good.
Press
So
on
you're
birdies.
pressing where?
On birdies.
Like right around here. Good. Use your thumb. There you go. Good. And you have the patient do what?
Flex his knee.
Stand on one foot. Stand on one foot.
Single leg stance.
And then you have him flex his knee
Yeah.
to 30 degrees. And as he's flexing, you're pushing, you're really digging into the distal IT band. And a positive sign is what?
Pain.
Pain. You got that? That is noble sign. You could also do this in supine,
Good job.
where the patient's lying in full supine. You hold on to Gertie's tubercle and you passively bring them into 30 degrees of flexion, but I don't like that one. Not that you can't do it. I like the standing one better. All right, what's the last test?
PSLR.
Actually, no,
No,
we
we
have
have
two.
Two more. Okay, what's the next one?
Over.
Pronounced Aubert in
Aubert.
France.
Obeer.
Ober, the Ober test. How do we do the Ober test?
On the side lying.
So do it. Show everybody the Ober test. Face the audience.
The audience. I can't remember this one either. Wait, scoot back this way. Wait, let it.
Very good. You extend, you flex the hip, the knee, you extend the hip, and you let it drop. If it touches the table, the IT band is not tight. If it hangs out, it cannot touch the table on its own. You're holding it here, and if you let it drop, oh, thank you. And it on its own, it's not, then that's clearly tightness on the lateral structure. Got it? That's a positive sign. I was like, for a second, what happened? You were good yesterday. And finally, one more test.
PSLR.
The passive straight leg raise test. So you go to the patient, you perform a passive straight leg raise.
You know all the degrees?
If,
If it's greater than 70 degrees of hip flexion, then the pain is coming from the leg. But if it's less than, if it's at like 30, then it could be from.
all right, so first, right, if you raise the hip and at 30 degrees or less, you see obstruction, that could be a sign of what? When you can't lift it more, that's a what sign? Sign of the buttocks, which means there's
Buttocks.
something else stopping the range of motion, which could be a tumor or some kind of issue with the nerves. It's non-musculoskeletal. Does that make sense? Because 30 degrees is about what? Nobody's that tight, right? If you get to 30 to 60 or 30 to 70 degrees and you see resistance, you feel resistance, and the patient says, oh, I feel some pain shooting down the leg, you think it's what?
Radicular.
Radicular pain. Very good.
I thought you said if it was at 30 degrees, there's pain. It's an SI joint issue. Is that not?
At 30 degrees?
More than
More
70.
than 70.
More than
More than
70.
70. 30 to 70 is radicular, and then you could go more than 70, and there's pain in the lower back, it's SI joint. If you get to 70 and he goes, ow, my hamstrings are tight, well then that's just tight hamstrings. But what are you looking for as if you think it's, yes, if you see lateral sailing of the leg, then that's another sign for tight lateral structures. You understand that? Very good. All right, did all the special tests. Congratulations. What about the red flag? How about if they have cramps in their leg?
Dehydration.
Calf cramps.
They have calf cramps in the leg, or it could be what? Dehydration.
Poor nutrition.
Poor nutrition. So if you're doing all these tests and he goes, no, it kind of feels like a crampy thing, then you're not thinking IT band. You ask them further questions if they're drinking right, eating right, all that stuff. Good. Now, what are we doing now? Stretch. How would you stretch the patient's tight IT band? I like to do your way with the extension.
Oh, it's the self stretch.
No, you do it on the patient.
The overstretch, like the same position as the over, right? And
Yeah, same position, but knee and extension. Show us. Just either keep them on or keep them off. So the patient is side lying. We're addressing the patient's right leg. The therapist is bringing the leg back, and he is then pushing down.
Like that.
Whoa. Well, yes. So here, slide further this way. It's this way. Slide further.
If he flexes knee, can we
Yes.
get more?
No, we go like this, and then
oh yeah.
that will stretch his IT band. Right? You're supporting yours doesn't kill himself, and you're just creating. You're putting the IT band on stretch. I like it. I like it. What else? It's good. Stretching the hamstrings. You could go straight now. How do you stretch the patient's hamstrings? Somebody.
Straight leg.
Good. Excellent. How do you stretch the patient's gastroc and soleus?
Come down.
Gastroc and how about soleus?
Huh? Oh yeah.
Yes. You put a towel underneath the knee for the soleus, right? Makes sense because the soleus does not cross
Right.
at the knee. The gastroc does. So if you bend the knee, you're taking the gastroc out of the equation.
Soleus stretching.
Very good. How would you teach the patient to stretch their own IT band? Kevin,
They're doing it?
their IT band stretch they could do on their own.
Stand up. Stand up.
Oh, you're talking to me.
Again, we're looking
You
for
got
teaching
3 other
strategy.
people.
Wait, I thought we were demonstrating on you.
Yes.
Giddy up.
How do you teach this stretch?
You put one leg behind the other,
Yep. Yes.
and you're gonna go towards the other side.
Towards which side?
The leg that is in the back.
Oh, okay.
And that's
And that's so the leg that's behind, you're stretching the same direction as the leg that's behind. That will stretch, in this case, the left IT band. At your left, and I feel it. You feel the stretch?
Yep.
Good. That is excellent. That is, and you can do it with 2 hands, like that, whatever. Okay, good. How do you manually stretch? How do you stretch your own gastroc? I mean, gastroc and soleus. Wall stretch. I like the wall.
Yeah.
Yeah. Show it. Good. If you're doing gastroc, your
Knee is
Straight.
straight.
your back knee is straight.
Soleus is
Wait, and your
straight.
back heel must remain on the floor for gastroc. For soleus, your back knee is slightly bent, and you should feel it more. Soleus. Very good. How do you self-stretch your quads? I mean, aren't your quads, your hamstrings?
laying down. Straighten your leg.
Straighten, and you can straighten your knee and make it harder.
Very good. Okay. Good. Strengthening. Hip abduction.
You're just standing with the TheraBand around your ankles, there's slight flexion and then just going like that.
Or an ankle weight.
Or an ankle weight.
Or an ankle weight. I also like, it's closed chin, but I also like the, where's the step? Where's the
It's over there.
Oh, over there.
Oh, yeah, we'll do foam roller.
Hip drop.
This is called the pelvic drop or hip drop, pelvic drop. But you're not bending the knee. Keep the knee straight,
Pop the hip.
and then there you go. That's working that muscle exactly like the patient has an issue with. Do you see that?
Right?
They're yeah, which glute med are they strengthening? The left glute med. You see how that strengthens the left glute med? To advance that, they could hold a weight on their right side and do the same exact exercise. Very good. We missed the foam roller. Everyone knows how to do a foam roller? From lecture number 3. So if let's say it's a distal IT band issue. How do you, so you go, yes, there you go. And you stay in a small area. Do not roll the whole thing. Roll a little more, a little more. Good. For how long should they do this?
5, 10 minutes.
I'd say 2, 3 minutes. I tell the patient if it's not hurting, they're doing it wrong. It should be uncomfortable. This is a lot of give though.
Yeah.
Okay, good. How do you strengthen the hip flexors on the treatment table? Diana,
Supine, just put on.
Show us. Show how you do it.
Oh, I don't.
Yeah, why not?
She's an injured
I have
too.
Oh, you have an injury? Yeah, but no, bend the opposite leg.
Oh.
There you go. This is the way I like to do it. Watch. Good.
Going
No,
Tight.
no,
parallel to
Oh, this one
This
up.
way.
Yes. Tighten your quad. Good. Lift your leg to the height of the opposite knee. Slow. Hold that for 3 seconds. Come down slowly. Slowly. Come down
slow.
Slow. Despacio. There you go. Stop right here. Hold that for 3 seconds. And then come up slowly. Hold that for 3 seconds. All the while you're tightening your quad. Because you can just do it. You don't feel anything. Good. I like that. All right. Very good. Core stabilization.
Posterior pelvic tilt.
A posterior pelvic tilt. Everybody know how to do a posterior pelvic tilt? Anybody not know? I like to put my hands right in the small of the lower back. Can somebody show us? So that they're doing it properly. Good. Knees bent. Take your hand and crush my hand.
Crush his hand.
Very good. Breathe. That's good. If this is too easy for the patient, I like the test that you guys did as a treatment. Do a bridge and hold that 5 to 10. So that's pretty. You feel it?
Mm-hmm.
Good. That's a good one. All right. Good. Manual technique. We need you, Ryan, because you have shorts. Manual technique to the IT band, lie supine. Who's going to show us a manual technique to the IT band? Kevin? Josh? You can do, let Josh do it. He can do this one.
He loves it.
Manual technique to the IT band.
Doing like cross friction.
Yes, but since he's a... Get in there.
I don't want like this.
Yeah, like this.
Turn it up. Oh, I thought you were supposed
Get
to go
in there.
perpendicular.
Yeah, I like...
Okay.
Get in there. Follow the IT band. Got it? Cross friction to the IT band.
Okay.
Where's the IT band? Well, if you could see, that's not IT band. Here's IT band.
Oh.
Wait till I tell Dr. Ross, Mr. Mitchell.
Wait,
Wait
this
till
is
I
back
tell
here,
Dr.
but I
Ross.
thought
You're
it
gonna come
attaches
back
up here.
Yes, you feel the IT band. It feels like a bump in the road. All right. You should feel people's IT bands.
Come on, ask him.
All right.
What?
You good?
Yeah, I thought is it not perpendicular?
Yeah, you can do perpendicular. I get.
Okay, all right, that makes sense.
All right, good.
Because it's like cross friction. All right, you're good.
Phase.
What?
You gotta bust a cat. All right, phase 2, stretching tight musculature. A more aggressive version of all the stretches. I would, a more aggressive version of all the stretching. So the one you did, that stretch, you could do, go into more stretch, right? Be more aggressive. Yes, go into, you could even do it, come over here. Come over here. Do the stretch. Face me. Do the stretch that you just did. And now bend your elbow, rest it here. Oh yeah. Look at that, that gets it more. So teach them to be more aggressive. Very good. What else? Good. Now how about strengthening? Closed chain eccentric. Modified matrix. That's not the movie. So explain it to these people. They don't understand. Everyone look at the modified matrix.
12 o'clock?
So we're treating which leg?
My right leg.
So the unaffected leg is at 12 o'clock. You see that? If there's a clock, the affected leg is at 3 o'clock. Very good.
And then I take.
The
Affected.
involved arm is in the air. Good. Uninvolved arm at your side. Very good. Brace the abs and lower the involved hip and rotate your body so involved arm touches the uninvolved side.
Oh yeah.
And that gets his right 1, 2. Here. Uninvolved, involved. Involved.
Turn out for what?
And you keep the foot back.
Yeah.
Yep, feet don't move. What, you always end up like this somehow.
Wait, give yourself more room.
Her hand doesn't go the other way.
She can't pronate when it's up.
You got it? Give yourself room. 12 o'clock, uninvolved leg. Where's 12 o'clock? All
I
right.
personally prefer the wall bangers.
Another one is called the wall bangers.
Bangers.
So stand. Now you're gonna stand with your feet about 6 to 12 inches apart
Over here.
from 6 to 12 inches from the
Oh,
wall.
yeah.
Good.
Like,
You're gonna you're gonna go into a squat and rotate your pelvis
And tap.
until you tap the wall. And you should feel it in your hip abduction.
Tap.
Yes.
you feel it?
Bang the wall and return to starting position.
Do I have to hold my hands out like this? Or am I just doing it?
You can.
It's good for balance.
And turn with you. No, but if you're turning, watch, you're like this. Yes, really get into it. Your feet are like, I feel it after the first one.
I'm sorry, affected side is on the wall?
Affected side is tapping the wall.
You-
Yes.
Yeah.
All right, the last one is the frontal plane lunge or the side lunge. Kevin, you like to show us a side lunge?
Are you cold?
Huh? No.
Be a little more enthusiastic about it.
Going to the side.
Yes, frontal plane lunge works the abductors. A regular old-fashioned lunge works whatever, but frontal plane lunge works the abductors. Got it? All right, and then I wrote more aggressive manual stretch. That's just your digging deeper. Thank you. More aggressive core stabilization. No, we're gonna show you a real one.
Oh, the ball.
Here's a more aggressive stabilization with a ball. Without killing yourself or anybody.
So there's two. There's where you're bringing the ball to your chest.
Miraculous.
So you're bending your knees, bringing your knees to your chest, and then the other one is your knees are straight.
Yeah, it's called a pike.
Mike.
Yeah, try this. This is hard.
If you want to get 23 seconds of a single, that's how you do it. All right, very good. Thank you. Wow.
Okay.
All right, good job, guys. Any questions for group number 2? Finally, group number 3. 16-year-old female cross-country runner referred to your clinic with a diagnosis of left shin pain from her PCP. That's primary care physician. He started preparing for the upcoming by running hardcore. This patient runs about 30 miles a week and began experiencing left shin pain about 3 months ago. Despite the pain, she continues to train for the past 4 weeks. The pain has significantly worsened. The patient reports that she experiences 4 out of 10 left shin pain while running, 0 out of 10 pain performing activities of daily living. Her goal is to return to running, I'm assuming pain-free. All right, guys, let's make this work, okay? Based on your patient's interview, you suspect the diagnosis is
Tibial stress fracture.
tibial stress fracture. Okay. What populations are susceptible to this diagnosis?
Elderly, female, athlete tribe, bone,
Elderly.
any people with bone disorders,
Yes.
and as I said, female athlete tribe.
The female unhappy triad. And what is the
Yeah.
female unhappy triad?
Poor nutrition, low body weight, and menstruation. These factors combined.
Irregular or missing a cycle.
Yeah.
Okay, the female unhappy triad. Let's have one person answer.
Yes.
Because my headache just jumped up to it too. All right, intrinsic causes. Let's go in order. Intrinsic causes of the diagnosis.
High arch,
High arch,
leg length discrepancy,
leg length discrepancy.
weak tight hip musculature,
Okay, what else?
decreased calcium deposition.
Yeah, so low lean body mass and low bone density. Or you say the fancy way, calcium deposition. I say low bone density, both the same thing. Very good. What are some extrinsic factors, next person in this group?
Poor training, poor footwear, bad form.
Yes, poor training, poor footwear, and bad form. That is correct. What is the gold standard to diagnose this?
MRI.
MRI is the gold standard. X-rays might come up what? Negative. Especially a stress fracture that's less than 3 days old, there's a very good chance it won't even show up. So the MRI is the gold standard. You, knowing this diagnosis, you think there might be a leg length discrepancy. Are you comfortable performing a leg length discrepancy test
Yes, I'll do
on
it.
a patient? Who would you like to do it on?
So it's from the ASIS to the terminal medial.
How do we find the ASIS on your patient?
So you do like the crease?
Yes.
So, do you mind if
So
I
you
touch
find,
it?
you find soft tissue
So here,
and you turn.
yeah, it's right there.
Right there.
I like to do this, Joe, you don't mind, right? Take this and
Yeah.
turn, feel for that bone.
Turn and feel good.
Good. Not everybody's so thin and in shape like in this class. And you go to the terminal medial malleolus.
Yeah,
Okay.
now I go on the other side
And you
too.
do both sides. What reading do we have?
33 inches.
All right, let's see if,
Not bad.
not bad. Terminal, yes.
Slightly a little bit more on this side, on the left.
Ooh, that explains a lot. That explains a lot. All right. Good. So that's how you do it. All right. To know the bony landmarks, you have to know how to use the tape. Right? Anybody could get that. You get leg discrepancy test. Make sure you know what you're doing. All right. So what hip musculature might be weak, and how would the person present in the single leg stance?
It may gluteus max
Well,
and
that's the next
gluteus medius.
Gluteus maximus and gluteus medius, and this person will present how so?
Trendelenburg sign.
Okay, Trendelenburg, yes. What else?
Miserable misalignment.
Miserable malalignment, which they look like what?
Huh?
Joey did it right. Joey did it right. You have internal rotation and adduction when they're standing on one foot. And okay, very good. Good. And you're gonna test the core. We already showed how to test the core. Definitely know how to test the core. All right. So the dynamic posture is you're having them walk or do single leg hops or single leg squats. And because an athlete might be able to stand on one foot without an issue, but if you feel you need to be more dynamic, you watch them squat or hop, and you'll fall into that miserable malalignment. Okay, very good. All right, Melissa, are you ready to do some special tests? Okay, which one would you like to do?
The heel tap.
The heel tap. So the patient lies how? Talk this one out. This is your
so-
big chance.
Yeah. Lie on your back.
Yeah.
Bring your
All right.
foot off the table.
Good.
Go home. Good.
Live. There you go.
And then I'm just.
No, you're
Okay.
tapping this way.
Oh yeah, right.
Do it like at the heel.
What test is this?
The heel tap test. Right, because the person, if the patient has a stress fracture, that tap would be uncomfortable. That make sense?
Yes.
Like that.
Well, do it.
Oh.
Sorry.
You give it a couple good taps, but not like a
Okay.
not like a love tap. You gotta push it.
Okay.
And a
You
positive.
should do it on the long leg, maybe it'll correct itself.
A little
Yeah.
dislocation. So what's a positive sign? What's a positive sign?
Pain.
Pain where?
Proximal.
Well, where the fracture is.
Yeah.
So the
So
patient
it'll be
says,
the tibia.
"Oh, I have pain right around here," and you do it, and that increases the pain exactly where they showed you, and that's a positive sign. So pain at the fracture. Very good. What about you want to do another test?
Sure.
Sure. What's the next one?
The squeeze test.
All right. The patient's sitting how? Very good.
Yeah.
Yes.
And then I would be sitting.
You find the position of pain where the pain is,
So
and then you
let's
are.
say it's here,
Yep.
and then I'm just squeezing out like that.
No, you're squeezing in.
All right.
Think about this is the bone. You want to crush that bone.
Yeah.
So squeeze. So go to either side of the bone, and now try to pretend you're trying to crush the bone. There you go. More
And
like this.
then-
Watch, like this. I'm not doing this. Sorry. This. I'm doing this. I'm
Okay.
taking either side of the bone, and I'm.
It's just pinches.
Yes, that's that. Now show me what's the next test.
The
Fulcrum.
The fulcrum.
And how's the fulcrum go?
Same as the squeeze, but one is more lateral and more
Yes, you're
Upper and
going
lower.
above and below the
Yeah, above.
place of pain, and you're doing like
That
this,
better?
like this. So here's where it is. I'm trying to do that. Show us again. Here, there shouldn't be any movement. It's just pressure on the bone. And a positive sign for all those?
Pain.
Pain, very good. In the area where the fracture is. All right, what about some red flags? Tell your colleagues about red flags in regard to stress fracture. I gave them the page and the paragraph, by the way. So what do we have to say about that?
Well, I saw some things, there was like night pain, increased tone of hip abduction, the assault or domestic abuse they cannot recall.
Trauma, accidents.
Trauma, accidents, assault of any kind that the patient may not remember, but doesn't want to talk about, so communication is important.
Do you have a question, Josh?
That's your question.
Some red flags in regards to stress fracture.
Some clinical signs and symptoms can be familiar to trauma, accidents, assault of any kind that patient cannot remember or just doesn't want to talk about, so communication is important.
Any questions?
I guess not.
No, so what's important about this is that a person, when you're if they get the patient's story for a stress fracture, if they got into a motor vehicle accident, a sports-related injury, if they have a history of a domestic abuse, these are all red flags of what things that could cause stress fracture. Or if even the unhappy female unhappy triad, all these things could make you think about stress fracture because you don't have an MRI machine. Good. All right. So your findings: there's no leg length discrepancy. They have weak hip musculature, typical for this diagnosis. Weak core, tight left piriformis. Ankle eversion is 3 out of 5. Patient presents with dynamic and static miserable alignment, and the special tests are positive. Great, you guys have the right diagnosis. So now they're in the subacute phase. So as we discussed, the doctor could say, I want them not to run, but I need you to strengthen them. But they're not running. So now you're gonna, in the first subacute phase, you're gonna strengthen with little or no weight bearing, right? You're not doing weight bearing, hardcore weight bearing exercises because they have a stress fracture. So you wanna strengthen in a safe position. Does that make sense?
Yeah.
Good. So how would we strengthen our glute medius, somewhat not weight bearing, isometric, and also core strengthening at the same time? Show us.
The side plank.
Show us the side plank. Side plank. So that gets the glute medius.
That was it.
That gets the glute medius. That gets the core. That gets the glute medius. That gets the core. Even though it's on the table, we'll consider that close to non-weight bearing. Look at that. Fantastic. Good. Next. Who's next? Who wants to show us non-weight bearing internal rotation? Somebody else. And glute med, but who's going to show us that?
I'll do it.
I didn't even hear. I want to see something good.
You do side raises. Oh, actually, reverse clamp side raises. Oh yeah, reverse. This is.
Wait, no. Your knee stays in.
Reverse clamp.
Reverse clamshells. Have you never done reverse clamshells? They don't do that in your gym?
He works on his pecs and his traps.
See reverse clamshells? You don't have gluteus medius day at the gym, no? All right. You saw that, reverse clamshells? Good, reverse clamshells. How about non-weight bearing hip abduction? Joe, show us.
Leg lift.
Think. Hip abduction, non-weight bearing on the table.
Just the IT thing. I'm trying to visualize this.
How do you strengthen your hip abduction and side lying?
Oh,
That's it. Hip abduction and side lying. Very good. All right. Melissa, are you ready for this one? You don't like this one? We're going to do it on the ball. So this is glute max, non-weight bearing with core and hip extension.
Can I do it on the stool?
Over there.
Yeah.
That's it?
Yeah. Do it. How about? Yeah.
You don't want to.
All
Teach it, yeah. You don't have to do it on the ball. I just want to see it done on the ball.
You wanna do it on the ball?
Liz.
So you're gonna do a plank for me.
Wow.
All right.
Okay.
Do a low plank. Low plank.
Low plank.
Low plank.
Okay. No. Yes.
Okay, and now you're gonna lift your non-weight bearing leg.
Well, yes. So that's, you see how that's glute. What is that? Glute max.
Thank you.
Hip extension, core. There you go.
Even.
You can do it in low plank as well. Do it in low plank.
What are you talking
On your elbows.
about?
Just regular.
Oh,
yeah.
but on the ball?
But the key, all right, I like to have your legs elevated.
Just regular. Yeah.
Oh, I see,
Not-
yeah,
it's
yeah.
non-weight bearing. See, non-weight bearing. Hip extension and core at the same time. You see that?
Should we do it on a stool then?
Yes, we did it on a stool, where the feet could be on a stool and you're doing a low plank. That works too. Very good. All right. Here, how about this one? Non-weight bearing core and hip abduction. Joanna. Non-weight bearing core hip abduction. And I'm going to say it's also glute max. Non-weight bearing core. Good so far. All right, where's the core? There you go. And now, do a hip abduction. No, lift up, and now do hip abduction. There you go. That's core.
Read.
That's core. That's hip abduction. It also, I'm going to say glute max. The glute max is keeping that leg from flying forward. You got it? So you're doing hip abduction. Everyone saw that, right? Very good. So that's the acute phase. Great. Patient is doing great. Goes back to the doctor. You're a fantastic PTA. It's time now to progressive. Subacute phase. Glute medius and maximus. Closed chain with therabands. Show us. So glute medius and max. So what are you going to show us first? Huh? Show us.
Yeah.
No, I can't see. No, you just basically do.
Good. That's glute medius.
Yeah.
How about glute max?
I kind of thought that was both.
No.
Walk backwards.
Someone,
Just walk backwards.
Just walk backwards?
Walk backwards.
Right.
That's good. All right. Now, single leg closed chain. Glute max and med. Yeah, I want to see something better than that.
Prong,
Oh, right.
prong with the knees, man.
Or no, but I want him between
Wrong with the.
weight bearing now.
Oh,
So you see, that one
Yeah.
works, but I also like the single leg deadlift.
time is involved.
On the involved side, if this is the involved side, bend the knee a little bit. You're not doing a squat. And you progress to use a weight. Got it? Good. All right. Plyometrics. Let's talk about plyometrics. How do you know the patient's ready for plyometrics? Darren,
Introduce
you
elliptical.
raising your hand?
Alright, so first you go to the elliptical machine.
First, we start with the elliptical machine.
Then you
And then
build
the
up-
patient is pain-free for how long?
30 minutes.
Okay, build up to 30 minutes. No, then you go on the treadmill. 30 minutes of
Vigorous walking.
vigorous walking without exacerbation of symptoms. Good.
That
How
was,
many weeks are they doing this for?
2 weeks of pain-free life.
And then they're ready for what?
Plyometrics.
Plyometrics, very good. Teach your patient plyometric progression. So we're first gonna start bilateral straight plane. You know what that means, bilateral straight plane? Bilateral straight plane? Oh, show us what's a bilateral straight plane. So bilateral means what? Two legs,
Squat
straight
jumps.
plane means, yes, squat jumps.
And then you can just do ankle jumps too.
Yes, ankle hops or squat jumps are bilateral straight planes. Easy. Now a medium for bilateral straight plane. Straight means one plane, right? Give me another one. Medium. Tuck jumps, Josh. No. You know, everyone knows a tuck jump, right? That's a medium.
Yep.
Very good. And now, what's another medium? bilateral straight plane?
Squats.
Split squats.
Yes, split squats.
Non-cycle.
And then non-cycled. And then a difficult would be cycled split squats. You got it? Review all of those from the plyometrics, because if you get this case, you will have to teach the patient and show the patient and know by heart this progression. By heart. Okay, now we're up to multi-directional bilateral. What are 2 examples of multi-directional bilateral? Melissa?
Lateral box jumps, that'd be easy.
Medium arms.
Yeah, box jump, yeah, okay. Lateral box jumps, I'll buy that. What else?
Barrier hop.
Lateral barrier hops, I'll buy that too. Okay, what else?
And the zigzags.
Zigzags. Everybody know what the zigzags is? Two-legged zigzags. We all know what we're talking about, right? That's review. Good, and then finally, we're doing something on a single leg. You can pick anything single leg. Single leg tuck jump. Single leg zigzag. Single leg lateral hop. Right? That's the last thing you're doing on the affected leg. And if the patient is able to do that, Darren, how many contacts makes them ready, perhaps, for actually running now?
300 to 400.
300 to 400 contacts. That means every time legs hit the floor, that's a contact. What does that equal, 300 to 400 contacts?
Quarter mile.
Yes, a quarter mile is 300 to 400 contacts. How about a full mile? Well, if one leg's 300 to 400 contacts, then 750 per leg is a mile. Very good. So they begin jogging at a slow pace for a quarter mile, right? Then what are you doing next, Liz?
Increasing the distance and the duration.
Slowly increasing the distance and duration. Melissa, how much should they increase per week? Or, yeah, the distance, let's say. What? 10%. So you start at a quarter mile for a full week, and then you jump up, what's 10% of a quarter mile? I don't even know. 2/5 of a mile. It's so much easier in the metric system. All right. All right, so you're doing 800 meters, and then a quarter mile is 200 meters, so you don't go more than 20 meters a week. Doesn't that sound much easier than a quarter? Yes. Guys, I don't want side talks about a quarter mile. All right. Good. That's it.
Yep.
Exactly at 5:30. Any questions on this lecture? Oh, wait.
But there's more.
There's more? No, there's no more. Next Tuesday is a quiz. Every group has their diagnosis, correct? Follow what I'm asking of you. Don't do this. Oh, let's make it super easy. So it'll be an easy quiz. Because if you give me crap, I will do the research myself and then quiz you on it. So the better you give me, if you give me a good body of research, not a million pages, enough to answer the questions, I will take the questions from your work. If you give me garbage, then I'll take the questions from my work. What's better?
Can you just give
Your
us
work. No, your work. Your work is better. I'm not giving you, if I